inquest is not present in, which type is not present in Indian court? We don't have medical examiner system. In America, if you do specialization in forensic, you can become a top man in the Department of Police. Coroners, it is not there, and trial by jury. Earlier it used to be there, later on they found that jury can be biased. Even a judge can be biased, but jury bias is a significant social problem. That means the culprit could influence a group of believable people. If it is India, you can only influence single judge. So trial by jury also is over, is not there. Incised looking wound, where will you come across? Typically it is a split laceration with a blunt object on a skin which is more having bone behind it. You will find incision like wound, cheekbones, lower jaw, iliac crest, perineum, shin, etc. are the classical locations. Post-mortem staining and rigor mortis are the favorite areas for the examiner. Typically, if you look at the post-mortem staining, it is common in dependent area. The surface of the post-mortem staining is not elevated, and it is also found internal putrefaction and hypostasis. Post-mortem staining can occur. Internal organs, external also. Recent JIPMER question is, what is the earliest location to find post-mortem staining? Is it right iliac fossa or under surface of the liver? There was a huge debate on that, so I left the literature for you in that discussion. Then cadaveric spasm. Cadaveric spasm doesn't wait for something. Yes, depth is right below the liver. So cadaveric spasm is called instantaneous rigor. Whenever there is any firearm injury or the patient has got a neurological trauma at the time of death, then that leads to development of instantaneous rigor, which is then called cadaveric rigidity. Until the rigor mortis persists, cadaveric rigidity also persists, is what you need to basically remember. Usually it is limited to single group of voluntary muscles and it usually involves the hand, is what I want to underscore. Sudden death, excitement, fear, severe pain, exhaustion, neurological dysfunction at the time of the death are the predisposing factors for the cadaveric spasm. Benzodine is basically to detect blood. So both hemoglobin, myoglobin can be detected by the positive benzodine test. What are the various subsections of the Indian legal procedure? Indian Penal Code, Consumer Protection Act, Criminal Procedure Code, Indian Evidence Act, they are all included under the Indian legal procedures, is what you need to remember. In what scenarios isolation of the patient is important? Now every school was told mandatory to write an email or send a notice to the parents that if your child has got a common cold, don't send him to school. If you send him to school, we will send him back home. So all schools they made it mandatory. On one side, health officials say swine flu is not by eating swine, sir. Swine flu is because of like any other flu, right? So that is the reason if we over advertise about it, that may create a fear psychosis in the people. That is one side a botheration. Another side is not educating the people is the thing that we are doing too much of martial inactivity, which is not correct. So both the sides we need to strike a balance. That's a whole challenge. So when I was in MD, that time we got this avian flu. Common cold patient also comes, you are worried, first will you get is the challenge. So diphtheria, measles, cholera, they are the scenarios where it is found to be. TB, typhoid, they found it is ineffective. Isolation is what you need to basically remember. Then acute hepatitis B. How to diagnose? Basically, there is a surface antigen, there is an IgM, there is a HBE. IgG occur not in acute state. core तो antigen available नहीं है, antibody ही available है. Screening is effective for which tumors and ineffective for what? Screening is not good for carcinoma lung, carcinoma ovary, carcinoma endometrium. But screening is good for prostate and breast and cervix is what you need to remember. Live vaccines are contraindicated in pregnancy. That's the reason rabies and hepatitis which are not live can very much be given in case of pregnant women. Oh doctor, 100 milligrams dates के अंदर आयरन कितना होता, विटामिन सी कितना होता, कैलोरीज कितना होता. You need to be master chef to remember each of these ingredients. Don't remember. अगर डेट्स के बारे में रिमेंबर करें तो एग्जामिनर के नाश के अबाउट मैंगो, अबाउट बनाना, सीताफल, अंगूर, मौसमी, बहुत कुछ है ना. हाँ, दैट्स अ होल चैलेंज. व्हेन विल यू रिमेंबर दिस काइंड ऑफ क्वेश्चन? और एक बार कहीं ना कहीं एम्स ऑल इंडिया पीजीआई में नॉट वन मोर टाइम, टू मोर टाइम्स इफ यू कम अक्रॉस डेट्स एंड इट्स quantities, then उसके बारे में सोचेंगे. That ability to say no must come to you. Then only you will finish all questions. Otherwise you will be sticky on only one thing. Before onset of symptoms only. Generally incubation period में patients will not be infectious. But there are exceptions. Measles, chickenpox, whooping cough, hepatitis A. End part of their incubation period में they are infectious. Incubation period only they are infectious is what you have to, communicable is what you need to remember. Endemic ascites is because of the Junjunia seeds, as all of you know very well. Then these four doctor are very important: aflatoxin, endemic ascites, lathrism, etc., etc. HPV vaccination, very high yield topic. Many times this is asked and it will be asked. What is quadrivalent, what is Gardasil, what is bivalent, etc., etc. Everything you should read about HPV vaccination, especially in our country where carcinoma cervix is very common. So quadrivalent papilloma virus 6, 11, 16, 18 become the Gardasil is what you need to basically remember. DEP is asking, lividity and postmortem staining are the same. Yes, postmortem lividity, postmortem staining is more or less same. Right. The HPV vaccination efficacy is more than 70%. Two types are available, bivalent, quadrivalent. They protect against 16, 18, or if you take quadrivalent 6, 11, 16, 18. And what is the age where the American College has recommended? Females 11 to 12 years of age with 3 intramuscular doses is what you need to give, and the second and third should be given after the first, after second and 6th month is considered to be the recommendation is what you need to remember. A child of 14 years met with a traumatic hyphema. Hyphema is the blood in the anterior chamber, doctor. Hyphema. So what are the various measures by which you manage hyphema is a very, very important question. Blood in the anterior chamber, how will you basically manage? Elevation of the head, bed rest is indicated, eye shield in the night suddenly if he is rubbing his eyelids, hyphema worsens. Don't give ibuprofen or aspirin like NSAID which is capable of causing more bleeding, platelet dysfunction. And we give tropicamide which is a short acting dilator, and we decrease the IOP because hyphema lead to decreased aqueous humor drainage and lead to raised IOP, and hence we use like acetazolamide is what you need to remember, and some advocate steroid. So this is the treatment of hyphema. What are eyelid tumors? is a very important question. Simple question actually. Squamous cell, sebaceous, melanoma, basal cell. Any of them can present like a eyelid cell tumor is what you need to remember. Retinoblastoma, I think when you look at the question you should remember, I read it, I invested time, I am going to rightly answer. And before answering only looking at options, you must know what are the 10 things examiner want to ask about retinoblastoma. Most common primary intraocular tumor in childhood is retinoblastoma that you expected. Commonly seen in children because we did not read in ophthalmology, we happened to read it in pediatrics for the first time. So we passed the ophthalmology exam without knowing retinoblastoma. Then that's all, simple question. आंख में दिखता है या नाक में दिखता? ENT or ophthalmology, if you know retinoblastoma, examiner is happy. So, sympathetic ophthalmitis, any injury in one eye will cause the release of the antigens from the dangerous zone of the eye. What is that dangerous zone? Ciliary body. And that in turn will lead to development of sympathetic ophthalmitis in the other eye and typically lead to uveitis. But after the injury, at least 4 to 8 weeks of time is required before the other eye get affected with sympathetic ophthalmitis is what you need to basically remember. Direct ophthalmoscopy, indirect ophthalmoscopy. From times immemorial, this is a favorite question. Advantages of one over the other, differences, किसमें magnification होता, किसमें real inverted image आता, किसमें virtual erect image आता, all those table, you have to be 100% sure. So, if you do direct ophthalmoscopy, then you can see the posterior pole of the retina is what you have to basically remember. Then ectopia lentis, lot of causes are there, at least 7 to 8 important causes, don't forget. Marfan, homocystinuria, Weil-Merkensenese, sulfite oxidase deficiency and hyperlysinemia. Common question क्या होता है? Marfan में how is it dislocated? Upward, outward. Homocystinuria is downward, inward. Is what you have to ultimately remember. We said no, Marfan is a tall guy. So you need to look upward, outward. Then diabetic retinopathy. You find all these things, neovascularization, hard exudates, flame-shaped hemorrhages, exudative macular edema, etc. Where do you find arteriovenous nipping? This is called, you can see here, arteriovenous nipping. This is a feature of hypertensive retinopathy is what I want to once more underscore to all of you. AV nipping. Retinopathy of prematurity. What is the truth about it? Basically, majority of cases, it will resolve by itself. Hyperbaric oxygen is a predisposing factor, not a treatment. It is not seen in full term, it is seen in preterm, and also the children who are lesser than a critical weight. So that's what you need to remember. So the neovascularization, rubeosis, iridis, etc., which you see with the prematurity. Then what is the difference between an adult larynx versus a child larynx? Child larynx होता है omega shaped epiglottis, and laryngeal cartilages are soft and collapsible. Sometimes laryngomalacia is very common abnormality, and larynx is high in case of children, and you can't palpate trachea that easily while doing tracheostomy. So where is infant's larynx position, doctor? It is high in the neck. It is opposite C3, C4, the level of vocal cords, at rest, and it will reach C1, C2 at the time of swallowing, much higher. And if you look at cricothyroid, thyroid spaces in the trachea, they are very narrow. That's the reason tracheostomy के time पे आप intuition use करके cut करना पड़ता है. That's important. Then which procedure is useful in choanal atresia? What is meant by choanal atresia? Typically, failure of the nasal cavity to open up posteriorly. Here, it got, you can see, it got completely blocked. It is unable to open up posteriorly. You can see, right? So, it is unable to open up posteriorly. Into the nasopharynx during the fetal life is called choanal atresia. Choanal atresia. If you do posterior rhinoscopy, not anterior, you can discover it. And choanal atresia के relevant syndrome क्या होता है? Charge syndrome. Coloboma, hearing impairment, choanal atresia, mental retardation, genital abnormality, endocardial cushion defects. Nothing is related to the other but for the charge. You need to remember. Huh? Then, how will you diagnose in a newborn baby? You pass a catheter, 8 French catheter, to the nasal cavity. If it can't pass more than 5.5 centimeters, अगर नाक के अंदर नहीं जा रहे तो you will suspect possibility of choanal atresia is what need to be remembered. All muscles are supplied by recurrent laryngeal except only one muscle which is cricothyroid, which is supplied by external laryngeal nerve, is what you have to ultimately remember. What are the other synonymous names? Just like Depp asked us a question, is lividity and staining are same? Examiner is also asking similar question. What are the other names given for otitis media with effusion? It is also called serous otitis media. It is also called mucoid otitis media, glue ear, secretory otitis media. ये सब एक ही नाम होता है. What are the tests for balance? Easy to guess. Dysdiadochokinesia is cerebellar dysfunction, so good for balance. Romberg also good for balance. And finger nose test for cerebellar dysfunction also will help you balance. Only thing you need to know what is Unterberger's test. Unterberger's test. For me also first time. For only with the class I prepared. Very simple. Typically you will ask the patient to close the eye and walk on the spot. Romberg में क्या करते हैं आप एक बार आंखें खोल के एक बार बंद करके you will ask him to walk on straight line. So if any swaying is there you will look for. Unterberger also is also more or less similar. It will help you to detect vestibular pathology, not central cause of the imbalance is what you need to appreciate. Now comes the general medicine. Superficial vein thrombosis generally involves cerebral white matter. But deep thrombosis which come due to embolism or in situ thrombosis, what do they commonly involve? They typically involve thalamus and basal ganglia. Whenever they occur, what happens? The vessel become very prominent on a plain CT itself, not contrast, plain CT itself. The vessel become very prominent. And common locations where will it occur? They occur in the basal ganglia. And what predisposes to this deep thrombi in the vessels? Pregnancy, OCP, infection, trauma, dehydration, anything can lead to the predisposition. Small cell lung carcinoma. One bronchogenic carcinoma, varieties, common question in the exam. So, small cell carcinoma, by the time you discover only, it will be metastasizing everywhere, unlike squamous cell carcinoma which is localized. छोटू कहीं भी घूम भाग सकता. Small cell carcinoma also don't remain in lung, it will run everywhere. उसको सर्जरी कैसे कर सकता? आप पूरे बदन को काटना पड़ता. लिवर में है लिवर को काटो, किडनी में है किडनी को काटो, सबको काट नहीं सकते. Surgery has no role. It is associated with smoking. And the remaining things are true. Paraneoplastic syndromes are common, neurosecretory granules are there in the small cell cancer. What is Menkes kinky hair syndrome? Typically in the people who are having problems in handling the copper. So typically you have decreased circulating ceruloplasmin, you have a hypopigmented or a brittle hair, and mental retardation, failure to thrive, and hypocupremia, that is decreased copper levels, not increased copper levels in case of Menkes kinky hair syndrome. And one more thing you should not forget is X-linked. Clubbing, where do you see? Asthma में clubbing नहीं होगा. अगर asthma patient में clubbing है तो you are missing something else. Maybe he had a bronchiectasis or maybe he had a underlying malignancy. Mesothelioma, pulmonary fibrosis, TB, sarcoidosis, anything can lead to development of clubbing is what you need to remember. Obstructive sleep apnea, doctor. They are all in the modern generation where obesity is a pandemic. Short neck, obesity, in the night time the uvula falling back and blocking the respiratory tract leading to hypopneic episodes. Life is a challenge when you are prosperous also, right? So when you are prosperous, you are attending too many parties, you are a president of a medical association, every day evening is a party, right? So there is a development of obesity and obstructive apnea. So the definitions are important for the examiner. Typically, what are the definitions that are associated? Any airway blockage more than 10 seconds defines apnea. And hypopneas, more than 10-second events in which there is a continuous breathing. Though there is a breathing, the ventilation is reduced by around 50%. Complete blockade is apnea. But uvula came blocking the airway, still some air is passing, less than 50% ventilation is there, more than 10 seconds become hypopnea. The number of episodes per hour is apnea index, and a apnea hypopnea index 5 to 15 means mild. And whenever it is 15 to 30 per hour episodes are happening, apneic episodes moderate and more than 30 become severe is what you need to remember. And snoring is a feature where upper respiratory tract obstruction lead to stridor, snoring, etc., etc. Where do you see hypernatremia? Generally, common rule, remember, a dehydrated guy is hypernatremic. Overhydrated, edematous guy is hyponatremic. General rule of thumb. Whenever you find 154, 160 hypernatremia in your patient, what is the common thing? You need to give, he is deficient in what? Total body water, pure water without solute. So in that scenario, you should not give normal saline to rehydrate him. You have to give pure water administration should go in, right? So typically in all these scenarios, severe brain trauma, suprasellar mass surgery, extensive burns, intercerebral hemorrhage, in all these scenarios hypernatremia can be found. But diuretics, whenever you give, the loss of fluid that occurs is generally isotonic. That's the reason you don't find hypernatremia. You may find normonatremia or at most hyponatremia. Both solute and water, both of them are lost in case of administration of diuretics is what you need to remember. When will hypernatremia occur? If you lose more water, lesser solute, then you get hypernatremia. But diuretics generally, what will they do? They make water loss, salt loss almost proportionately. Hence, isotonic loss will be there. Then doctor, what leads to secretory diarrhea? Doctor, diarrhea, 4 varieties you should remember. Secretory, osmotic, exudative are the 3 common varieties. And 4th is mixed type. Okay. So, what is meant by secretory diarrhea? Whenever condition like cholera, what will happen? Cyclic AMP levels will elevate and that lead to secretion of electrolytes into the stool and secretory diarrhea will occur. Okay. Commonest cause for secretory diarrhea is increased active secretion of electrolytes into the diarrheal fluid. What is one feature that is so characteristic of secretory diarrhea, which is not a feature of other types of diarrhea. If you decrease the feed intake, the secretory diarrhea doesn't stop, it continues to happen. Whereas osmotic diarrhea, exudative diarrhea or any other type of diarrheas may, if the food intake is decreased, osmotic diarrhea, obviously food is the main source of osmosis, so that will stop the diarrhea. Where non-secretory diarrheas may, यहाँ तो food, stopping food doesn't stop the diarrhea, then you call it as secretory diarrhea. One more point after going home you need to read is, what is osmolar gap? How to differentiate osmotic versus secretory diarrhea? एक table रहता है Davidson में, that you need to review. One question will come if at all diarrhea comes. Crohn's disease, ulcerative colitis में what you have is exudative, etc., etc. I leave the literature for you. CRF versus ARF, acute renal failure versus chronic renal failure. From morning to evening, a nephrologist's main energy किस में जाता है? One decision. First, is it renal failure or not? Second, if so, then is it ARF or CRF? If so, does it need biopsy or no biopsy? If so, does it need a renal replacement therapy or not? If so, either anybody available for renal replacement or not? If so, can they afford the money or not? There are 5-6 things every day, morning to evening rounds you will take care. So doctor, if you take anemia or acidosis, hypercalcemia, hyperphosphatemia, hyperkalemia, it can occur both in acute and also chronic renal failure. Anemia, generally the school of thought is, unless the renal failure is very long standing in nature, anemia doesn't occur. Right? But you take the example of TTP or HUS, hemolytic uremic syndrome. इसमें hemolysis है, anemia हो रही है, hemolytic uremic syndrome, uremia भी है. So it is an ARF, but still you have anemia. But general rule is, anemia is a feature when there is a chronic renal failure, anemia is not a feature if there is a acute renal failure. But that is not always true. Acidosis दोनों में हो सकता, electrolyte disturbances दोनों में हो सकता. But what is the difference between ARF and CRF then? Small sized kidney. Actually A should not be there in the options. I mean A can be there or not, depends whether examiner knows that HUS is ARF but still anemia is there or not. Right. So peripheral neuropathy also is a feature. Unless chronic renal disease has progressed to stage 4, peripheral neuropathy doesn't occur. After going home, what is another common topic you will read, doctor, homework tonight? What are dialysable, if you do dialysis, reversible, irreversible complications of the CRF? Is a favorite question. Then similarly, already you know, fractional excretion of sodium. Based on those features, how to differentiate pre-renal from renal from post-renal azotemia. वो भी एक table रहता है Davidson में, वो भी पढ़ लेना. And anyway, we discussed all these things in our online video library. Comfortably you can review, but ARF, CRF is a favorite topic. Only 7-8 topics in nephrology for entrance exam. Right? Glomerulonephritis, ARF versus CRF, like that. Now, acute rheumatic fever may, you have Caricombs murmur, pancreatitis. Then what is the specialty of arthritis in rheumatic fever? Arthritis will be migratory in nature and it does not leave any residual joint disease. Hence rheumatic fever is called, it licks the heart but bites the heart. Heart may, it will leave permanent sequelae, not on the joints. Chorea. Chorea is a late sequel. 2 common questions about rheumatic fever and chorea. What is the rarest of all Jones criteria in ARF? Chorea, Sydenham's. Rarest. Which feature, if it is there even alone, you don't need any other features, you still diagnose ARF, rheumatic fever. Chorea is what need to be remembered. And what is rarest of all? Chorea is what you need to remember. What is commonest of all among the Jones criteria? Carditis. Then past history of streptococcal infection will also be there. Caricombs murmur? Caricombs murmur, I'll come to that point. Caricombs murmur, is it mid-diastolic or early diastolic is your doubt? Early diastolic murmur means what, doctor? Aortic regurgitation. General rule. याद रखो. Mid-diastolic murmur होता है mitral stenosis. मगर acute rheumatic fever में mitral stenosis नहीं होता. मगर mid-diastolic murmur क्यों होता? That is a doubt you should ask yourself. I'll tell you why it happens. Can give you the board. Another 5-6 questions we'll discuss and call it a day. Yeah. So, doctor, what are we discussing? Why mid-diastolic? I am suffering short spells of amnesia. I don't know. Maybe I am getting ready for a early Alzheimer. So we are talking about right? Okay. Caricomb. No problem. If I forget everything, also the videos I delivered are always there, right? So until it is Glasgow coma last stage, I still remember how to teach. वो तो होता है. It is ingrained not just in my voice but in my soul. So Caricomb, doctor. See, whenever the heart get enlarged in acute carditis, what happens to the ring? Ring get dilated. That lead to development of regurgitation. And once more, all that regurgitated blood has to pass through the same valve. Two things will lead to a murmur. Through a stenotic valve, normal flow, or a normal valve, increased flow. And because of this increased flow, what will you get? Caricomb murmur, which is acute dilatation of the ring in a dilated heart with an increased flow due to the regurgitant blood plus regular blood lead to that. Later on in the late stage, mitral valve becomes stenotic, chronic stage mein. Then even normal flow will lead to mitral stenotic murmur, which is basically which one? It depends. If there is any AR, significant AR, but Austin Flint or Graham Steele or mid-diastolic rumble, they are all the features when there is a long-term sequelae of the valvular heart disease in a chronic rheumatic heart disease. That's the point. Okay. Now, Vishwa is asking a very good question. Most common arthritis hota ya carditis hota? There is also another difference in the epidemiological value. Some books saying 40% there, 50% here, but please do check. One third question hota hai earliest out of all. Earliest out of all, commonest out of all, rarest out of all, most specific out of all. Jones criteria. Okay. So that's important. Then doctor, another 5 questions will finish up to 125 and call it a day. A patient has got HIV and TB. What is their protocol? Basically ATT drugs versus ART. ATT drug should be given before ART is a true statement. Then if you are giving ART plus ATT, the ATT adverse effects will be more commoner if the receiving patient is HIV positive also, is what need to be remembered. Then rifampicin among the ATT is a P450 inducer. So that is the reason it will affect the protease inhibitors, making them ineffective. And if you take zidovudin like drugs, it is not affected by the rifampicin. So no dose requirement, adjustment is required for this zidovudine. Then where do you see acute flaccid paralysis? Flaccid is what? Lower motor neuron. Any neuritis like Guillain-Barré syndrome? Any André cell involvement in poliomyelitis? Or any spinal cord involvement as in transverse myelitis? They are the underlying causes leading to AFP is what need to be remembered. Then doctor, where do you see pulsus paradoxus? It is seen in cardiac tamponade, but it is not specific for cardiac tamponade. What is pulsus paradoxus? Normally increased venous return into the left side of the heart, into the right side of the heart will put pressure on the left sided chambers so that left ventricular output into the peripheral pulse become low, and that lead to diminished pulse at the time of inspiration. That become exaggerated and altogether pulse become absent, so the heart is beating. That is called pulsus paradoxus. Exaggeration of the normal phenomena of a inspiratory fall of the pulse which occur is basically called pulsus paradoxus. Why it's called paradoxus? Because pulse is not felt, so the heart is beating. And where do you see? Whenever there is any hypovolemic shock, pulmonary embolism, cardiac tamponade, and many other conditions like COPD also, where high positive pressures are created, that lead to pulsus paradoxus. Where do you see loud S1 doctor? Loud S1 hota hai mitral stenosis. But for the S1 to occur loud, the valve must be pliable. There should not be any concomitant MR. It should be only pure mitral stenosis. Then only loud S1 will be a auscultatory finding. Oh, this question require our next class, because इसके बारे में बहुत कुछ बात करने का होता है. Metabolic alkalosis, chloride responsive, chloride non-responsive, we will discuss in more detail. Okay, doctor. So thanks for the patient listening, and thank God today no broadcast disturbances.